Let me introduce UnitedHealth Group for those of you who don't know. UnitedHealth Group is a Fortune 20 or so company with over $100 billion in annual revenue. I'm the Chief Medical Officer for UnitedHealth Care, which is their benefits division, covering now up to 38 million covered lives. So we represent all that benefit side, and then the other part of UnitedHealth Group, led by or characterized by a division called Optum, is focused primarily on developing health services for the delivery system, for hospitals, for other health plans, for other carriers, for physicians, and so forth. And they're focused primarily a lot on data and health information technology. They have some care management programs and also a pharmacy benefits organization. So our footprint, again, $102 billion annual revenue, about 6,000 or so contracted hospitals, over 500,000 contracted physicians, 80,000 contracted pharmacies. We characterize ourselves as competent in 3 areas. One is clinical care management. 2 is data and data management because of all the claims. We process over 1 million claims a day in terms of insurance claims, so there's a lot of robust and rich information. And 3 is information technology and so forth. So if you, from a CEO perspective in terms of innovation, we have innovation in all 3 areas. Clinical care delivery, payment reform, insurance reform, value-based benefits, value-based payment, different types of practice innovations and modernization in the practice of medicine, both from a consumer point of view as well as a physician point of view. But we also have innovation, obviously, in data management as well as technology, software, mobile apps, analytical applications, and so forth. So that's the introduction of UnitedHealth Group. What I want to do is, in terms of giving it a global view, where is healthcare headed? And you know, we basically have a fairly dysfunctional, if not completely broken, healthcare delivery system. Payments don't align with objectives. Outcomes have historically been an afterthought, or not a thought at all. So it's been well characterized from a couple of years ago, a Health Affairs article about the triple aim, basically summarized by the better care, better health, and lower costs. That what Nolan and Berwick did in their article was point out that basically what we have is we need, in order to fix the healthcare system, we have to have a common objective. And then once we have a common objective, we have to have a business model, i.e. incentives, to reward alignment and aspiration and movement toward those common objectives. In this case, the common objectives of the triple aim is a better healthcare experience for the consumer, and improving their individual experience, improving population health, both in terms of quality outcomes and so forth, as well as controlling the inflation of per capita healthcare costs, right, with a segment of the economy that's well over 18% of GDP and $2.5 trillion. The issue here is basically how can we sustain a new and improved healthcare delivery system? How can we fix what's broken? You can see in terms of the text that I chose to highlight is that the problem and the root cause of the malalignment on the triple aim is that the business models of virtually all healthcare organizations depend on keeping these 3 aims basically separate. And what our aim to do as UnitedHealthcare is to basically align those business models. That's where you come in. What are the revenue streams? What are the marketing and growth opportunities that will be successful? And we believe, whether it's in the delivery side or the information side or the mobile app side or medical technology side in terms of medical science, they have to strive to achieve the triple aim. If not, then we're basically doomed to failure. The next slide is a little busy. I just want to highlight the underlined areas. Basically, in terms of UnitedHealthcare, from a benefits business, and you can see where the services side and technology can help out, is that integration of care management programs, transparency programs, high-performing networks, value-based benefits, and the insurance design, as well as value-based contracting, must be aligned in order to maximize value basically characterized by higher quality and lower cost. And if we can do that right, and we have to do it right, then we'll have maximum value. So it's not just a matter of, well, can the medical science and the medical programs be clinically relevant to achieve higher quality, lower cost? Well, how can we pay providers and physicians and hospitals and other care providers? How can we pay them based on those types of outcomes? So it's more value-based payment instead of volume-based payment. Similarly, how can we reward consumers with what I call reciprocal incentives to have them do the right thing too? So it's not just rewarding providers to have higher quality, lower cost, but how do we reward consumers with insurance benefit design, for example, richer incentives, lower out-of-pocket costs, lower office visit copays, lower co-insurance on the part of the patient, if they do the right thing in terms of managing clinical outcomes, if they practice better, healthier behavior, if they choose more cost-effective and higher quality providers. I want to just, in one slide, basically show parallel paths for the reciprocal incentives. So on the one hand, the consumers are, and this is something that we're experimenting with on a constant basis at UnitedHealthcare, developing more and more consumer incentives for more evolved and better behavior. So it's not just basically they get richer benefits, richer insurance benefits, lower out-of-pocket costs if they do more and more of the right thing, whether it's characterized by choosing the most cost-effective drugs. You see here in the tiering of a pharmacy benefit, all the way to choosing better providers or engaging in healthier behavior, and ultimately improving health outcomes. So we have a diabetes health plan, which is, again, incentives designed in an insurance product where if consumers who enroll in a diabetes health plan, they're either diabetic or at risk for diabetes, and they practice the appropriate behavior in terms of following diabetic guidelines, then they'll have a lower co-payment, lower out-of-pocket costs, richer benefits, including $0 for tier 1 drug prescribing and so forth, basically free drugs that's covered under the insurance premium. That elevates itself to preferred providers. So they not only do they have healthier lifestyles, but we'll have products. We have products now in terms of if they choose more cost-effective providers, they will have richer benefits as well, lower out-of-pocket costs. Ultimately, we go to a plan like our personal rewards plan, where they actually improve outcomes, whether fasting glucose is manageable or controlled, or if they manage their blood pressure or lipid, cholesterol level, they will actually have richer benefits as well. So that continuum has to be emphasized. And I use that as an illustration. On the provider payment, same thing. Basically, this is a continuum where we're moving from volume-based payment to value-based payment, whether it's going to include performance-based contract, and more of provider compensation. Physicians and hospitals are going to be based on what the outcomes that they are attributed for in terms of the population that they're managing. This is very, very important because up until now, one of the real problems with American healthcare is the fact that providers have been paid historically on the basis of volume. The more you do, the more you get paid. This is really going to shift the paradigm so that the better they do, the more they'll get paid. And that's critical. So I use this as illustrations just so from your perspective, any type of innovation, whatever type of vehicle or product and service that you're thinking of, it's not enough just to be fresh and not enough to be new. It has to be something that's going to impact the triple aim. It's going to help either simplify and take out unnecessary costs, administrative costs, so that we can have better care. It's going to have to improve outcomes, whether from the consumer side or the physician side, in terms of decision support or ease of adoption and so forth, to improve better quality or better health. And then, or it has to drive out costs, both again, either from an administrative cost point of view, or actually lower and bend the trend, so to speak, on medical costs. Thank you.